Well, I will be speaking on the preferred practice pattern in cataract with PDR. Well, as we all know that diabetic patients are 2 to 5 times more likely to develop cataract, and that too at an earlier age. And significant number of those patients undergoing cataract surgeries are actually diabetics. So it is very important for early recognition and treatment of diabetic retinopathy before doing the cataract surgery, which actually influences the final visual outcome. Now, we're aware of this advanced diabetic eye disease, that is fractional RD, persistent vitreous hemorrhage, or a neovascular glaucoma. This all conditions can be associated with the cataract. Now, a proper planning is very important. We might line up into 5 scenarios. The first scenario is a cataract with a PDR. Second is a cataract, already the vitreous hemorrhage has happened. The third scenario is a cataract with a tractional retinal detachment. Fourth scenario is cataract with neovascular glaucoma. And the last one is a cataract with no visibility. Diabetic macular edema has been excluded and it's already been taken care by Dr. Ghosh in the earlier presentation. So coming to the first scenario, cataract with PDR, when the visibility permits, we have to administer the panretinal photocoagulation. But if the lens opacity precludes a preoperative PRP, it can be administered as an indirect PRP immediately or within 1 week of cataract surgery. Uncomplicated phacoemulsification generally does not lead to diabetic retinopathy progression. And if it does, it is mainly due to the poor glycemic control. Now, this is an example where the quiescent retina after PRP and cataract surgery can recover up to 6 of vision as well. So coming to the second scenario, that is cataract with vitreous hemorrhage, the B scan is very important. We need to rule out tractional retinal detachment. The combined, if there is a tractional retinal detachment, we have to take care of the tractional component as well. And presence of pre-existing PRP scars associated with a better outcomes. And now coming to the preoperative use of injection Avastin, it has been proved that it actually results in rapid regression of the retinal neovascularization as early as 24 hours. And there are several small retrospective series reports which says that it might have a role. But DRCR.net protocol AN actually showed that when compared with anti-VEGF versus intravitreal saline, it actually showed no difference. So there are certain surgical pearls. We should be very cautious in lifting the posterior hyaloid membranes, which is actually 100 times more added compared to the in normal cases. Intraoperative bleeding is a concern. We need to increase the infusion pressure, and endocauterization is a must. With the wide field viewing system, what we need to do, we need to ablate the retina up till the ora to prevent the rebleeding. And when cataract limits the visualization, obviously we need to plan a combined surgery. But the the risk for the combined surgery is if there is a severe PDR, it increases the risk of NVI and NVG. So these are the third scenario where the cataract with the tractional retinal detachment, it might be an extrafoveal or it might involve the fovea. As we know that a TRD, if it is there for 6 months, it might be associated with photoreceptor damage. Broader areas of adhesion, there is a chance of membrane reproliferation, so the vitreous should be dissected as far as possible. We can observe the extramacular TRD, and silicone oil as opposed to long-acting castoprone decreases the incidence of recurrent bleeding. So most of the cases in the bad TRDs, we prefer to use oil over gases. But the recent advances of the viscodissection, curve scissors, segmentation, and delamination gives a more predictable results in these bad cases as well. Combined surgery has an advantage of faster recovery, better post-op visualization of the retina. As I already mentioned, it is associated with 4 times higher incidence of NVG. So in high-risk eyes, cataract can be performed later if it is possible. We can do the TRD and later on plan the cataract. And obviously, here there is a role of pre-op intravitreal Avastin, and preferably it is given within 1 week of injection. Many prefers 3 to 4 days. And few reports suggest that if you use anti-VEGF in a bad severe TRD cases, which might actually result in crush syndrome, which is the worsening of the TRD due to anti-VEGF. This is one of the cases which is a favorable outcome after the surgery, combined surgery. And there's another scenario, which is the cataract with NVI, prognostically not a great case. Prompt treatment with PRP induces regression of the new vessels from the before the cataract surgery. We can use the anti-VEGF either intercamerally or intravitreal, which actually causes the dramatic regression of the neovascularization. Phaco with or without TRAB and vitrectomy should be considered at earliest once the NVI regresses to enable the treatment of the posterior segment pathology. However, the visual outcome following the phaco in this eyes with NVGs are usually poor. TRAB with antibiotomalites or any drainage shunt, generally the results, the success rates are bad. Combining phaco with endoscopic diet laser photocoagulation is the last option. So to conclude, the number of people with the diabetes is definitely increasing. So is the cataract. The diabetic patient with visually significant cataract pose a unique challenge during the surgery. However, with careful pre-treatment of the diabetic retinopathy and minimally invasive surgical techniques, the visual recovery is mostly quite good. But most important part is the patient education about the prognosis and the results of the surgery. Thank you.